out of 3 in the general population.
Oh, Margaret,
Yes.
Wayne is asking what Pamora is.
Oh, so it's peripheral mu opioid antagonist, and we're going to talk about that when we get to the opioid effects of the GI tract. Basically, it's like your Movantik and your Relistor that you use in your patients on opioids, but we'll get to that. And so then the other thing is functional dyspepsia, so epigastric pain. In the United States, it's about 12% of the population in adults. And you can see it kind of peaks in the 40 to the 49-year-old patients. So that's something you can keep in mind in clinic to be like, oh, hey, look, you could develop functional dyspepsia. We don't know exactly why it peaks in the 40 to 49-year-olds, but we know that that is there. And so as we look at that, now let's start going into the cases. So this is one of my gastroesophageal reflux patients. So she has had heartburn since 2010. She's 69. She has a history of Sjogren's and Raynaud's. So here in my head, I'm thinking, okay, so she has some kind of mixed connective tissue type disorder. She has these symptoms of heartburn, and despite being on high dose of omeprazole, 20 milligrams twice a day, she feels that there's still burning going up in her throat. It causes her to cough. She has regurgitation and the heartburn that can wake her up at night. And once a month, she can feel like she has stomach acid in her mouth. She's not having any weight loss. She's not having any early satiety. And so here's her other past medical history. There's no GI malignancies. And so even before she's seen me, she's already had workup from her rheumatologist. And so in 2010, she had an esophagram that showed some esophageal dysmotility. And then she had an esophageal ring and reflux, but in a small hiatal hernia, and the little pill and the mini marshmallow could pass pretty well. And then after they got that esophagram, they did an EGD and they dilated her. And it shows on the biopsies that she has a reflux. So then, because rheumatology also worries about the amount of reflux it gets in patients who have scleroderma or any kind of mixed connective tissue disease, because it can also affect the lungs. There was an esophageal manometry done and a pH impedance. And so when they're looking at her esophagus, when she swallows, she fails pushing the bolus of liquid down. And then she does have off her acid reducing medicine, real acid reflux. So this D-Meester score of 32, which is abnormal, means that she does actually have acid reflux. There's actually acid in the stomach going into the esophagus. And then it's confirmed on an EGD that shows that she has esophagitis on her EGD. So what do I do? I said, okay, what do we need to do? And these are things that I know this is what you do in clinic. So we're going to say, okay, let's continue the proton pump inhibitor. And then we're like, well, maybe she's having more symptoms at nighttime. Maybe also let's add a H2 blocker. And so as you and I would do, we would do famotidine, 20 to 40 milligrams, and you can kind of play with it and say, hey, why don't you try 20 milligrams first and then go to 40 and then see if we can cover those acid reflux episodes at night. And then she says, after, we do this for a couple weeks, maybe about, 8 weeks or so, she says, well, my heartburn is better, but I'm still having this coughing and regurgitating at night, and it's just waking me up at night. And so other things that I think about for patients, not just mixed connective tissue disease, is, okay, what am I missing? Because esophageal reflux, we have reflux going down into the stomach, and then it should progress past the stomach to the small intestine in terms of acid and food. And so then I'm thinking to myself, okay, am I missing something else? Is it the stomach that's not working? Other workup I have to think about is, okay, maybe it's because she's having worsening reflux and she's having this regurgitation at nighttime because her stomach isn't working or it's not moving as well. So we do get a gastric emptying test, and she does have gastroparesis. And then I do some trials of Reglan, but she had akathisia with that. So I use in GI motility clinic, I have to reach far for other medications to use to help move the GI tract. So one of the things that I use in clinic is something called prostaglandin, which you will be familiar with because it's used for myasthenia gravis for those patients who have the acetylcholine receptor disease. And so what prostaglandin does, it can also work on the GI tract by moving at, by using the acetylcholine, it's an acetylcholinesterase inhibitor. So it will continue moving the acetylcholine so that you keep on, you can activate the nerve, which then activates the muscle so that you have peristalsis. And so the prostaglandin helped. It slightly decreased her regurgitation and coughing when she wasn't asleep. And so I follow up her symptoms. So even though I'm moving her stomach, she still thinks she doesn't feel it as much, but now she feels like she's still aspirating at night. And she's still waking up with a little bit of more coughing and regurgitation of her stomach fluid. So, I maxed out her acid reducing medicine. I've provided motility so that I can actually move her esophagus and move her stomach. So then I think, what other treatments can I do for this poor lady who has acid reflux? And then these are, again, all the things that everyone would do in clinic. I'd elevate her bed. I talked to her about her meals. And then I said, and then we talk about, well, hey, would surgery be a good idea? But for her, it wouldn't be a good option because if you're doing a Nissen fundoplication, right, you're doing a 360 wrap around her lower esophagus. And if her esophagus can't push very well, she'll just have more, she would have just more dysphagia. And even if they did a partial wrap with esophagus that doesn't move, it couldn't overcome the pressures that they put for that wrap. So then I'm like, okay, let's review the definitions of heartburn. So this patient, she has refractory GERD because we have her on a double dose of PPI. We've even put her on famotidine, and up to 12 weeks, she still has continued acid reflux. We've even controlled her motility and have her esophagus moving a little better and her stomach moving better. There are times where patients have reflux hypersensitivity, where they have symptoms despite acid reducing medicine, but she has continued weak acid reflux. So I don't think she has that because I tested her with an EGD before, and despite me putting her on high dose of the PPI and the H2 blocker, I did a pH test during an EGD and it was still acidic. And then there's functional heartburn, which a lot of us will see in GI clinic too, which is basically like you have symptoms of reflux, but when you look at pH testing, there's no acid reflux. And so they're just kind of, it's functional. It's any kind of reflux. It's any reflux that's going up, they're responding to that, which is just like your irritable bowel syndrome, right? We're going into that functional realm. So what else can I do for this patient? So two things that I can look at, there's antacid alginate. So this is like your Gaviscon. And so in theory, what can happen is when you eat food, there is in theory, a gastric acid pocket pool above the food that promotes reflux after eating meals. And so what you do is you use this alginate, which is Gaviscon. So it's like it's like that stuff that you find on top of kelp. And when it contacts the acid, it forms this barrier. It's a polymer that forms a barrier on the top to prevent acid from refluxing back into the stomach. And so studies have shown that using antacid alginate or Gaviscon is quite helpful for the patient. I would say that the alginate is, when you get the Gaviscon, is thick. And so usually they have to pull it in a syringe, like 5 milliliters or so, and then they push it into their mouth because it's really thick. I mean, you can certainly put it on a spoon, but it's pretty thick. Another one that I like to use, especially because she talks about how she has a lot of reflux at night, I like to use baclofen. So baclofen, right, we usually use in patients to help their skeletal muscle and relaxation. But in the GI world, what baclofen will do is it actually tightens the lower esophageal sphincter. The lower esophageal sphincter has these ways of just relaxing transiently. So it decreases that and strengthens the lower esophageal sphincter. Other things for heartburn, you could use citalopram, fluoxetine, or amitriptyline, which also helps. And so follow up with her, she's actually doing much better. So we have her, and so she's on maximum therapy, right? She's on BID PPI, she's on an H2 blocker. We have her motility movement, and we also put her on baclofen. I didn't use the alginate in her. It's a little bit difficult for her to swallow that because she also has dry mouth. And so I'm controlling acid, I'm providing motility, and I'm actually using baclofen as a barrier to tighten up that lower esophageal sphincter so she doesn't have that coming back. And so she's actually quite comfortable with that. So in the GERD patients, we're maximizing acid reducing therapy. Always consider gastroparesis if you're like, why are my treatments not working? Because usually the majority of the time they should. And then refractory type medications are the alginate, the baclofen, SSRI, and the TCA. So before we move on, are there any questions that you may have, or I can wait also after the talk about any questions about refractory GERD? Okay. So here is a diarrhea patient case. So the chief complaint of this patient is that he just has diarrhea and he also has gastroparesis. So this is a 59-year-old male and he has biopsy-proven pulmonary and sarcoidosis. And he also has idiopathic gastroparesis. He already has a G-tube in that he uses for venting. So if he gets bloated and feels uncomfortable, burping is not enough for him, he'll open up his G-tube to either let gastric fluid or air go out. He also has chronic intestinal pseudoobstruction and is on chronic TPN. And so he has even been evaluated at the Mayo Clinic before. There's some type of infiltrative disease in the small bowel, but they haven't actually formally diagnosed sarcoidosis, though I think it is. I think that's what's going on. But the thing is, with chronic intestinal pseudoobstruction, you can actually see on his CT scans or his small bowel follow through that there are actually dilated loops of small bowel. And that's what distinguishes chronic intestinal pseudoobstruction from someone who has like just small bowel motility disorder, right? With small bowel motility disorder, the small bowel actually looks normal and it's transiting things through, and it may be a little bit delayed. But with someone who has chronic intestinal pseudoobstruction, they actually have delay in transit, but they actually have on imaging dilated loops of bowel. And so he comes in with complaints of gastroparesis, diarrhea, and inability to vent his G-tube to his comfort. And so, but then with his diarrhea, he was like, Dr. Eugenio, I work at Les Schwab. I'm super busy when I'm there. I'm carrying around my TPN every 2 or 3 hours. It doesn't matter. Throughout the day, throughout the evening, I get up in the middle of the night. I have just watery bowel movements. And he did have C. diff, but that was treated with vancomycin and fidaxomicin. And so then that was the negative. So he complains of his diarrhea, but then he also, every time he tries to eat, he gets severely nauseated and he tries to vent his G-tube. So he can't get any nutrition by mouth. He's doing this all for pleasure, eating for pleasure. But if he starts to eat food, he gets severely bloated, severely nauseated, and it causes him to vomit. And he tries to vent out his G-tube, which he just kind of opens up, and sometimes they hold it over the toilet bowl or in the sink, but he feels that he can't fully vent all the gastric contents out. And this is with like a 20 French tube that he's using. And so we do, again, many things that you would do as an outpatient. So for his gastroparesis, we tried Reglan. I even tried to use the liquid version and put it down his tube, and that wasn't helpful. Zofran sublingual was not helpful. We tried a scopolamine patch, but that caused a skin reaction. We even tried a chemo type anti-nausea patch, granisetron, but then that also caused a skin reaction. I put him on other motility medications. Another one that I use is something called bethanechol that helps activate the nerves of the GI tract, which then helps with GI motility, but that didn't help. The pridostigmine, which I had talked to you about before, that decreases nausea a little bit and improve vomiting to once a week. And then with diarrhea, we're doing all the things that we would do in regular GI clinic or in primary care. Loperamide wasn't helpful. Lomotil wasn't helpful. I thought, well, hey, he can't move his GI tract very well. He has dilated loops of bowel. Let's try to treat him for small bowel bacterial overgrowth, because that can cause bloating and diarrhea as well, but that wasn't helpful. We tried a tricyclic antidepressant to see if you could even use that, because the side effect would be from a TCA's constipation, but that wasn't helpful. Then I also thought, well, he has a bunch of bile acids that aren't moving through, from the production of the liver. But then we couldn't use that because he just couldn't tolerate taking the cholestyramine powder. And then pancreatic enzymes, I said, well, maybe something, he might have some fat malabsorption, even though his pancreas worked okay, but he wasn't able to swallow those or get those absorbed very well because they would come out of his G tube. So we're trying a lot of things. So then I have to think about, okay, let's think about chronic intestinal pseudoobstruction itself. What does it do? So it causes a hyper secretion of gastric acid and fluids. And so it will reduce the pH in the GI tract to an optimal level, so that he does have fat malabsorption, because we can't, with the reduced pH, it inactivates the pancreatic lipase and deconjugates bile acid salts, which causes more diarrhea, right? And so it's similar to patients who have short gut syndrome. And so this is kind of what's driving his diarrhea. So other refractory things that I have to go to and look at are, we bump up, so you have to, I told you that it decreases acidity. So one of the goals is to increase your acid reducing medicine so that you can have kind of more a neutral pH. So I put in his TPN, or his primary care, put pantoprazole IV BID, so we can max out his acid. They could also maybe also add famotidine if needed. But what I did try is I did try octreotide in him. See, which I know that I have seen in palliative care notes that you've tried this, that you all use this also for diarrhea. But I used octreotide because I know that it increases small bowel transit time and reduces the fluid losses, and it's effective. And so why do I want to increase small bowel time? From a GI perspective, I do, because if I have some kind of normal peristalsis, then it has better absorption for all these extra fluids. And so then it's much better for the patient. And so then the other thing is, he's stable, but if he starts having flares, I'll either check him for C. diff, or I'll treat him again for potential small bowel bacterial overgrowth or intestinal methanogen overgrowth, just with antibiotics like rifaximin, augmentin, doxycycline. There's a whole list of them in the literature. So follow up, after starting the protonics and the octreotide, he was doing so much better. He was only stooling 4 times a day. He didn't have fecal urgency. It actually had a little bit more form. And so then his complaint was, well, Dr. Eugenio, I still want to eat for pleasure, but I still can't vent the contents out of this G tube. So he actually went to a surgeon at Virginia Mason for this device called an Aspire Assist. So there's no data on this, but we just know that the Aspire Assist device is actually approved for bariatric surgery. So essentially, patients can eat a bunch of food and they have a G tube, and there's a pump that they connect to it. And so after they eat, they can pump out the gastric contents. And so this is actually FDA approved for bariatric surgery, but it was an idea we could think for the patient to kind of increase his quality of life so that he could actually eat for pleasure and get rid of the food. And so I think it's still pending, but the last I checked with this device, the company was probably dissolving, and so they probably weren't going to be doing this. And so he'll probably come back to me in clinic so we can discuss what else we can do to help with eating for pleasure and helping with his gastroparesis. So the conclusions are, think about the pathophysiology of what is causing the diarrhea. You know, if they have a history of abdominal and pelvic surgeries, they may have small bowel bacteria overgrowth because it can be predisposed for that. Do they have chronic intestinal pseudo-obstruction? Do they have short gut syndrome? On a CT scan in the past, do they have chronic pancreatitis that you can see? And you can see calcifications. And so then maybe pancreatic enzymes will be helpful. If they've had a resection of their ileum or their terminal ileum, then you have to think about, oh, bile salts could be causing diarrhea because that's where bile salts are absorbed. And so you can think of using cholestyramine. And so, you know, other refractory things are, you know, maximize, if you're thinking of, you know, short gut syndrome type pathology or chronic intestinal pseudo-obstruction pathology, maximize the acid medications that they're on, and then also consider octreotide. And so I'll pause here. Are there any questions about diarrhea?
So Dr. Burtis has a question about the meds that you discussed. So have you had insurance barriers to obtaining those, such as like the rifaximin or the octreotide for your patients?
Yes, so rifaximin always, because they insurances will only approve them for IBS with diarrhea, which you can certainly put that diagnosis down because, like I said, even though patients have like they can also have overlapping functional GI disease. So you can certainly put that down. But then there are other medications too in the literature that one can use. If you can't use rifaximin, there's like a whole list. And I'm sorry, I don't have that here to treat SIBO and intestinal methanogen overgrowth. And it's things like Augmentin, Bactrim, ciprofloxacin, metronidazole that one can use for like a 10-day course to see if they get better. So in terms of the octreotide, yes, that is usually always declined. And so I have a letter that basically says that, hey, this is why I have to use the medication. This patient has this disease, like chronic intestinal pseudo-obstruction, and I have to tell them it's like short gut. Or I can say, hey, I know that their small bowel does not move very well, and so it's kind of like short gut. And then I have a basically the data that I put, the references that I put here, I put that in my letter to say, you know, this is what's happening, and this is why we have to use this, and here are all the medications that I've tried, and then I usually get it approved. And so my letter, and it's patient specific. My letters usually I'm able to get it approved after that. It just takes a while, and I apologize to the patients for that. And then what you could do too, right? Some of the patients, if they're on TPN, they are able to, if you get it approved, they are able to inject it themselves. So they can either do sub-Q, but then, you know, that's every day. But if they already have TPN in a line and they already know how to inject medications, they can do IV pushes. Or sometimes the TPN company, if they are able and the insurance covers for it, you can mix it in the TPN as well. So you have like the sub-Q, you can do IV, and you can also do in the TPN, depending on the infusion company. Any other questions?
Margaret, can you go back a couple of slides
Yeah.
to the, let's see, one more, I think. I want to say it was when you were talking about, yeah, that one. So for the gastroparesis, do you do you go down, is that sort of algorithmic? Like you try the metoclopramide, then you try the ondansetron, then you try the scopolamine patch, or uh, are you thinking, are you using them in order like that? Or how do you think about that
So
for
usually,
refractory gastroparesis?
yes, usually I always try to provide a motility agent. So Reglan is a motility agent. And I know that you can get it in the United States and it's approved by the FDA so that we can use it. And then I'll do it concomitantly, like to control also the nausea. So I'll use Zofran at the same time. And then if Zofran is not helpful, they'll still be able to take Zofran, but then maybe I'll say, oh, let me see if I can add a scopolamine patch to see if we can help control the nausea better. And then you can just use the Zofran as needed instead of scheduled. And then I go down. So like for instance, you could get domperidone, right, which works like Reglan, but it doesn't have the tardive dyskinesia side effects of Reglan. But it's hard because you have to get it through Canada. It's not FDA approved. The reason why it's not FDA approved because in the 1970s, 1980s, women were using domperidone for increasing breast milk production. And so that's why the FDA stopped approving it because they were worried it was getting to the kiddos. But then I pull out in my back pocket the Bethanechol first because it's GI and it's GI specific. And then pyridostigmine, I use that kind of last because it's more systemic side effects because it will affect all the parasympathetic. You can get parasympathetic side effects like increased lacrimation, drooling. Sometimes people get tongue-tied with it. So that's how I usually go down to use that for gastroparesis.
And the bethanechol and the pyridostigmine, do you feel like those are covered pretty easily, or do you have to?
Those are easily
You
covered.
don't have
They're
to
old
do
school.
any
Those are
pre-auths.
old school medications. And it's only in, and it's not like there's a lot of literature on it. And the literature is mostly for esophagus. And the studies are limited to like under 30 patients. And so there hasn't been any like new studies. But with gastroparesis, right, we just don't have that many treatments for it, aside from just Reglan, an oral version and a nasal version. And so it's pretty hard to treat gastroparesis.
Yeah, I think that, we see a lot of patients with gastroparesis who kind of like this patient want to continue to eat for quality of life.
Yeah.
And it's really hard. So yeah, that's, I appreciate the discussion. And then Dr. Burtis is asking, do you ever refer patients with gastroparesis for gastric pacemaker?
So only in, I usually refer them when I have tried everything. And so it's the best data is for the diabetic patients with nausea and vomiting, like that the Entera or the gastric neurostimulator will do. And it just decreases the nausea and vomiting. So it can decrease those visits to the ED where they keep on going to the emergency room for nausea and vomiting. But then I would say here at the university, we also have the option of doing a endoscopic pyloroplasty. And so basically with some of my gastroparesis patients and some of the general GI doctors do this as well. You can, you use all the medications that you can. And then if not, then you take them to EGD and see if you can like dilate the pylorus to see if they have improvement of their symptoms. And sometimes you can Botox the pylorus, so you're relaxing and dilating it. So then it's just a straight gravity, gravity's going down and you have a more open area so that food can go down into the small intestine. And then if they respond to that and they can sustain, um, you know, there's that they have a sustained symptom management, then sometimes some of our therapeutic GI doctors can do an endoscopic pyloroplasty. It's called a GPOEM, and which basically they're going in endoscopically. So no cut, and I tell them, no cuts in the abdomen, and they do a long cut into the stomach to the pylorus, to the muscle to kind of open it up and see if that helps. So then when you reach that point and then things aren't helping and you're still having a bunch of nausea and vomiting, and you're on a GJ tube and you have to get J tube feeds, then you would consider, hey, maybe we need to get the neurogastrostimulator. I'm not as much of a fan because I feel like people get lost and they don't follow up. And then so they have this device in them, that sometimes people just don't follow up on. And I'm like, is your battery okay? And then the two institutions that do it is Swedish and Virginia Mason. The Swedish has a good program for it. Other questions on gastroparesis? Okay. So, sorry, everyone. Okay. So then this case is one of my favorites. It's the opioid-induced effects of the GI tract. Okay, so I have this patient who first came to me complaining of dysphagia. So she's 57 years old. She has severe depression and she has to undergo electroconvulsive therapy. She has a history of chronic pain. I think it was like knee pain and back pain. And she had been on Suboxone since the age of 43. And then she recalled like 10 years later that she was eating a donut hole and then she had dysphagia and syncope. She was admitted to the hospital, had a negative cardiac workup, negative pulmonary workup as well. And then the next year again, she had another choking episode after eating and collapse. And she's noticed that, a year after starting Suboxone, she's always had these esophageal spasming episodes. She just feels like it's a tightening in her chest. And then she has dysphagia to solids and liquids. So I had already done EGDs on this patient and it looks normal. And she has a history of like PTSD as well, sexual assault, very refractory depression, no GI motility, or I'm sorry, no GI malignancies in the family history. And so I did a bunch of stuff, just as we would always do. I'm like, okay, dysphagia, do you have reflux? So I use high dose PPIs. I use some Carafate, famotidine. I was like, well, if there's esophageal spasming, can I decrease her muscle tone a little bit with dicyclamine or hyoscyamin? Maybe there's some of the heartburn, and so let's use. She used nortriptyline in the past, Cymbalta and gabapentin, which all were not helpful. I did it upper endoscopy. I even even though it was normal, I did an empiric dilation to see if that helped. And then so all these things were not helpful. So I said, well, let's get a manometry to make sure I'm not missing some kind of echolalia, and we'll get some pH testing as well. And so what's really cool, so here she is on opioids. And so in this picture, this is esophageal manometry. Here is the upper esophageal sphincter here. Here's the lower esophageal sphincter, and it doesn't really relax. So when it relaxes, it's here, but this red means it's pretty contracted. And then usually when you swallow food, you should be able to see a picture of like this esophagus with the bolus moving down this way. But when she swallows, it's just one column. And so when we look at this in the surgery world and the GI motility world and in GI, this is echolalia. This is what we would see to diagnose echolalia. And so this was her on opioids. And then it took a really long time. It took about a year and a half or two to get her off opioids. And I even sent her to the surgeons to consider, hey, you should get a surgery for this. But I said, wait a second, wait a second. We need to get you off opioids first. Then when she's off opioids, you can now see that it's relaxing so much better here in the lower esophageal sphincter. And you can actually see that this is what the esophagus looks like as it pushes down the bolus. It's not like this column. It actually looks like an esophagus. And then I said, okay, well, also let's see what's happening with your stomach. So when she had on opioids, she had delayed gastric emptying. She had 32% retention and normal is less than 10. And then again, I took her off her opioids and now she only has 2% retention, which is normal. So the thing that was causing her dysphagia was the opioids. And so in the United States, when we look at opioid use, it has really gone up. And I'm sorry, I don't have more information except from the 2017. You can see the rise of opioid use here in the United States. And when we look specifically at how opioids affect the GI tract, the things that we can find are they can get on manometry or on a barium esophagram, this distal esophageal spasm. All this means is that their lower esophageal sphincter is a little tighter. You can have things that look like echolalia. You can have things that look like a jackhammer esophagus where it's just contracting very, very vigorously. In the stomach, we can see gastroparesis. In the colon, we can see opioid-induced constipation and also pelvic floor dysfunction, which I'll talk to you about in a second here. And so, her dysphagia got better after she was off the opioids. And but then she always, at the same time when she was complaining of dysphagia, she also said, well, I'm also constipated. My stools are hard. I have to strain a lot to have my bowel movement. Sometimes I have to rectally disimpact. And so we did some workup and she has dysnergic defecation. So what is that? And just for you to know, with opioid therapy, the side effects, so you can have vomiting, which could be attributed to just opioids itself, but could also be gastroparesis and the nausea as well, and then also constipation. So the way that opioids cause constipation or can cause problems with decreased gut motility is that the opioids actually bind to these mu opioid receptors in the GI tract, and those binding there decreases motility in the GI tract. And also when you look at the pelvic floor and how it works, it also causes pelvic floor changes as well. And so when I look also at patients, I look at the constipation, I'm like, okay, so opioids can be causing the constipation and slow transit in the colon, but then I also always have to look at their pelvic floor. And so what I'm trying to see is when you have a bowel movement, basically the question is, are you relaxing your anal sphincters, i.e. pelvic floor muscles, when you have a bowel movement, or are you contracting them so that you're causing a you're causing a blockage, like your rectum is pushing, but you're blocking because your pelvic floor and your anal sphincters are contracting. And so here in defecography, so this is us at rest. So it's actually contracted so that we don't have a bowel movement. And this is at rest. And you can see this angle. And then when we relax, this muscle relaxes, the puborectalis, we increase this angle, our anal sphincters relax, and then we can have a good bowel movement. So first what I do for her is I was like, okay, before we work on your, let's work a little bit on your constipation. And so these are the different types of FDA approved medications for constipation. The first three, Amitiza, Linzess, and Trulance, they work on the chloride channels of the GI tract, which promotes motility and also so patients can have looser stools. Motegrity and Zelnorm have just come out, or not just, but are out now these are the 5-HT4 agonist. And so essentially for patients who have constipation, they have decreased serotonin production in the gut. Whereas patients who have diarrhea, they have increased serotonin production in the gut. So the way that these work is that it's increasing the serotonin production in the gut so that you can overcome your constipation. And that's the motility and the cell norm. So the patient says, okay, I'm using Linzess. Sometimes the stools are still a little hard, but they're better, but I'm still straining a lot to have a bowel movement. And so here, this is her MR defecography. So I'm actually having her, there's contrast in the rectum, and this is where she's supposed to be stooling. This is the defecography, defecation maneuver, but she's contracting her anal muscles and her pelvic floor, so none is coming out. So opioids can cause this as well. And so this is just a study that shows that opioids, a third of patients on opioids have a sensation of anal blockage. And we look at it on anorectum manometry, which is a little bit. And so the other medications that we can use for her, because she's on Linzess and that's helpful, are these peripheral acting mu opioid receptor antagonists. And so essentially what it's doing is it's blocking the effects of opioids on the gut. So here it's competing against it, but it's not going to work on your central nervous system and block the effects of opioids on the brain. So they don't get withdrawals or side effects, or withdrawals from the analgesia effect. So these are the medications that we use sometimes as an inpatient. We can also use them as an outpatient. So oral, Movantik, Relistor, and Simproic. And basically you just have to see which ones your insurance will cover. But for those patients who cannot take oral medications, or you're worried that it is not going to be able to be absorbed, the only one that has a subcutaneous option is the Relistor. And so then this study here is just saying that when you use naloxegol or a Pomora, it improved anal sphincter relaxation. And so that's what basically I used for her. And so for this patient, she's actually doing much better on Relistor and Linzess, and her dysphagia has improved and her gastroparesis has improved. And she went back on a little bit of the Suboxone because she needed it for pain. And so I just keep her on these medications and she's doing pretty well. Okay, so I know that in palliative care and addiction medicine, you don't use the terminology narcotic bowel syndrome, but in the GI world, our Rome 4 criteria, just like how the psychiatrists have their DSM-5, this is our criteria for narcotic bowel syndrome. So it's this frequently occurring abdominal pain that's managed with high dose or chronic opioid therapy. I don't have an alternative GI diagnosis like Crohn's disease or ulcerative colitis. And you have increasing pain despite increasing the doses of opioids. And there's incomplete resolution when you escalate those, worsening of pain as the opioid concentration wanes, progression and duration of the abdominal pain, and then this has to be at least for 3 months. And so I have seen, chronic abdominal pain that is also that they had it and they did do well on narcotics, but then now they have like chronic abdominal pain as the primary care providers or whoever keep on increasing their opioids. And it's super hard, right? Because it's this opioid-induced hyperalgesia, which is related with the glial cells and inflammation. And so what's really hard is trying to take them off, because sometimes the opioids do make them functional, and we want that. And so, if treatment plans are there where they can have adding in antidepressants or SSRIs to kind of help with that, and trying to even reduce the opioids to like the lowest level, that kind of helps. It doesn't show so much that, you can use Relistor or any of the Pomoras to help. But hopefully there'll be more, data on that. Basically, it's like trying to treat the constipation, trying to treat the gastroparesis, etc. But the treatment plan, is trying to get them off the narcotics. But then on the other hand, when I see the patients, I'm like, well, I know that you have to be on it. So let's just try to concentrate on treating the constipation and see what we could do to see if that helps. So the conclusions are, just be aware that opioids can cause GI symptoms, and Pomoras, you can use them as a treatment tool. There's always narcotic bowel syndrome that's in the differential diagnosis on patients with chronic opioids with abdominal pain. And then this was just a side. We always treat the patient as a whole. In my GI clinic, I try to. And, chronic pain affects all dimensions of a person. There's studies that show that mindfulness-based stress reduction and cognitive behavioral therapy for chronic pain is helpful because it can improve physical functioning, decrease pain intensity, decreases depression. But then we also have to remember too that we're providers and we need to do wellness for us as well. And so there are studies that show that if we do the attention to breath, mindfulness, which only takes like 5 minutes or so, 5 to 7 minutes, that we decrease that negative emotions and things that we have in the amygdala, which is shown here when we do attention to breathing. And so and I've tried it a couple of times. It's really nice. And I've also done it with Dr. Krishnamurthy. But it's just, there are many different websites and things on Spotify that one can look at to do mindfulness, just attention to breathing, which is kind of helpful just to like reset you when you have a hard day in clinic or a hard day on the wards, just to remind yourself that we're just people and we're just trying to help. So that's all I have for you today. Thank you.
Thank you so much, Martin, that you mentioned that opioids could contribute to. Do you see more women with that, or do you see kind of equal amounts of women and men? And does it matter if you, had a child previously or gave birth previously?
So in the general population, even if you're not on opioids, it's basically 1 out of 3 who have fecal incontinence or pelvic floor dyssynergia. It's pretty common. And so what is helpful is I refer them, even if they are on opioids also, to pelvic floor physical therapy, which they have at Harborview, they have at the UW. I think they have it at Northwest too. But what they'll do is like, it's actually pelvic floor physical therapy, and they also do biofeedback. So the pelvic floor physical therapist. And I always tell them, I was like, it's a different type of therapy because they have gloved hands. They're going to teach you how to breathe, how to sit. They may feel your pelvic floor and your groin area to feel what your muscles are doing when you are doing a defecation maneuver or when you're relaxing. Sometimes, and I tell them, sometimes they even have to manipulate the muscles in your pelvic floor. So whether, with the rectal exam and feeling the levator ani muscles, and to actually manipulate them so you actually know what it feels like to relax your pelvic floor, because some people don't. And so then when they understand that, in studies, the biofeedback portion of the pelvic floor physical therapy, 70 to 80% of patients will defecate better and have improvement. So that's available through the university in all sites.
And it sounds like you've had success with that too.
Yes, and it's covered by insurance.
Oh, that's good.
The other thing is, when we were talking about the different constipation medicines like the Linzess. So, those are all after, I've tried Docusate, Senna, magnesium, all of the things that they can use out of pocket or pay out of pocket or get, because those other medications can be pretty expensive. So if you do use those and patients have commercial insurance, they can go on the website and they can get a savings card. So it's sometimes, and then Medicare and actually Medicaid will cover them, but for like Medicare, sometimes they're, even though it's covered only quote 80%, the patient's still ending up with a bill of like $200 or $100 per month. So sometimes that's when I use, say, okay, well, let's try to optimize Senna and Docusate if you can. And if not, then we can certainly try, the Bothanicol to see if that helps you a little bit, along with like the Senna and the Docusate, because then that's you don't have to get that a prior approval. It's a cheap medication to use. And that's kind of how sometimes I have to navigate my patients 65 and older, when they tell me, oh my gosh, Dr. Eugenio, it's $250 a month for Linzess or Trulance.
So we're at time. I guess my final question, just for anybody who's on for the last minute. So you mentioned Docusate, which we tend to like. I feel like it has kind of fallen out of favor or like by the wayside for a lot of our patients, just because in advanced cancer and it just hasn't really been shown to be effective. However, are you using it still?
I don't use it. I use Senna. Yeah, I don't use Docusate. I use Senna, Bisacodyl, because I know that Senna and Bisacodyl will actually has motility effects on the GI tract. What Docusate doesn't.
Got it.
I also use like magnesium that helps, magnesium oxide, like 400 to 800 BID.
Okay. And polyethylene glycol, I guess.
Yes. And I use that one too.
Okay. And Lauren Carpenter is just reminding us that the VA also has pelvic floor therapy.
Oh, that's good. That's good.
Yeah. Okay. So I'm going to release everyone. But thank you so much for answering my questions too. This was super
Thank you all for
helpful.
having me. I really appreciate it.